Have you ever found yourself maybe caught in a loop of intrusive thoughts? Those really relentless obsessions? Or felt this overwhelming urge to perform certain compulsions and noticed it all just ramp up around a specific time of the month, maybe right before your period? If that sounds familiar, you are absolutely not alone. It's a remarkably common experience, yet one that's far too often dismissed or maybe just misunderstood. Today, we're going to deep dive into the compelling, scientifically grounded connection between menstrual cycles and obsessive-compulsive disorder, or OCD.
Yeah, and what's truly fascinating here is how something many people experience as a really private battle,
Yeah.
feeling too sensitive or maybe overly emotional at times, is in fact a verifiable biological phenomena. We're going to unpack the research that reveals why your body's natural rhythms can profoundly influence OCD symptoms. And critically, what that means for how we approach care, how we think about treatment.
So, what does this all actually mean for you? Our mission for this deep dive is to explore that crucial biological link, understand how these hormonal shifts really impact your daily life, and maybe most importantly, what tangible steps you can take to find more effective, more personalized support. Let's get into it.
Okay, so to kick us off, maybe for anyone who needs a quick refresher, how would you describe the core components of OCD? And, why is it so debilitating for those who experience it?
That's a great place to start. So, at its heart, OCD is a chronic and incredibly debilitating mental health condition. It's really driven by two main forces: obsessions and compulsions. Obsessions are those persistent, unwanted thoughts, images, or urges that just pop into your mind. They cause significant distress or anxiety. Think of them like sticky thoughts you just can't shake, maybe a fear of contamination, overwhelming doubt, a relentless need for things to be perfectly ordered, or even deeply disturbing impulses.
Right, those intrusive thoughts. Exactly. And then compulsions are the repetitive behaviors or mental acts you feel driven to perform in response to those obsessions. They're an attempt, really, to reduce the anxiety or maybe prevent some dreaded outcome. So that might look like excessive washing or meticulous checking, counting, maybe adhering to really rigid routines.
It sounds like this endless, exhausting cycle.
It is. It's this cycle where the attempts to feel safe often just end up reinforcing the distress. That's what makes it so hard to live with day to day.
Okay. And parallel to this, we have the intricate dance of hormones throughout the menstrual cycle. Could you simplify the key hormonal shifts that happen and maybe why some phases might be more impactful than others for, mental health symptoms?
Absolutely. So your menstrual cycle broadly cycles through distinct hormonal phases. You have the follicular, the ovulatory, the luteal phase. But the crucial point for our discussion today is what happens in the luteal phase, particularly right before menstruation. In this phase, both estrogen and progesterone levels, which have been relatively high, start to drop, and they drop quite rapidly.
Ah, okay. The drop.
Yes, this significant hormonal withdrawal, this drop-off just before your period, seems to create a critical vulnerability window for mental health symptoms, and that includes OCD. It's not just the presence of hormones, it seems, but the fluctuation and particularly that decline that plays a key role.
Wow. And here's where it gets really interesting, I think. The research powerfully demonstrates that major reproductive events, so times characterized by these profound hormonal fluctuations, not just static levels. These are periods of heightened vulnerability for both the onset and the worsening of OCD.
Exactly.
I mean, imagine almost half of women with OCD facing a predictable spike in symptoms just before their period. That's the kind of powerful premenstrual link the research reveals. We're talking like 49.7% in one significant study.
Yes, it's a striking number. And we see this pattern consistently across several key life stages, which really reinforces the connection. For instance, at menarche, that's puberty, the initial surge and shift in hormones seemed to be a potential trigger. Some research found that OCD onset occurred in the same year as a person's first period for a notable 22% of subjects studied.
22%. Wow.
Yeah. Then we have the premenstruum, that late luteal phase we just talked about, right before the period starts. This is consistently identified as a time of increased vulnerability. A substantial proportion of women with pre-existing OCD, the numbers range from maybe 20% to as high as 49%, report significantly worse symptoms during this phase.
Worse in what way, typically?
Well, it might mean intensified intrusive thoughts, a real spike in anxiety levels, maybe obsessions becoming much more time-consuming than usual. And it's often associated with other premenstrual mood symptoms too, like increased anxiety, irritability, sometimes even depression.
That sounds like a particularly challenging time of the month, a kind of double whammy.
It really can be. And then What about during and after pregnancy? These are also periods of massive hormonal upheaval, right?
Absolutely. Huge shifts.
They are. Pregnancy and the postpartum period are incredibly significant windows of vulnerability. The research shows a worsening of pre-existing OCD in about 8% to 16% of women during pregnancy itself. And often, the content of the obsessions is directly related to the fetus, like contamination fears leading to increased washing rituals.
That makes sense.
But the postpartum period truly stands out. Some researchers call it a red zone. Between 29% to maybe even 50% of women experience a worsening of their OCD symptoms after giving birth. And it can happen quite rapidly, sometimes starting as early as the second day after birth.
That quickly. Wow.
Yes. And it frequently manifests as what we call ego-dystonic intrusive thoughts of harming the infant. Now, it's vital to stress these are unwanted, anxiety-driven thoughts. They are the opposite of what the person actually wants or intends. They do not mean the person will harm their baby. But these thoughts cause intense distress, obviously.
Of course. Leading to more compulsions.
Exactly. Often leading to avoidance behaviors or checking rituals, trying to keep the baby safe. And we should also mention, new onset postpartum OCD can affect maybe 3% to 5% of new mothers who didn't have OCD before. And finally, just to complete the picture, some research indicates that OCD onset or worsening can occur during menopause as well. Again, further supporting the profound role of hormonal shifts across the lifespan.
It's really clear that these hormonal shifts are major players. And you mentioned PMDD earlier, premenstrual dysphoric disorder. The co-occurrence of PMDD with OCD seems to really highlight this kind of synergistic interaction, doesn't it?
It does. For anyone unfamiliar, PMDD isn't just typical PMS. It's a severe hormone-based mood disorder. It affects about 5% to 8% of menstruating individuals and causes really disabling emotional and physical symptoms, predominantly in that luteal phase. It's debilitating. And the very fact that PMDD is now an official diagnosis in the International Classification of Diseases, the ICD-11, further validates this whole concept. It shows these cycle-driven mental health challenges are rooted in biology, they're medically recognized.
Right. So if we dig a bit deeper into the biology, what's actually going on? You mentioned serotonin earlier.
Yes, the serotonin hypothesis is a pretty well-established idea in OCD research, the thinking that low serotonin levels are linked to the disorder. What's fascinating is how hormonal fluctuations, especially those premenstrual ones, seem to disrupt serotonin levels. This could directly contribute to that symptom exacerbation we see. Both estrogen and progesterone appear to influence serotonin signaling in the brain.
Okay, so it affects the neurotransmitters. What about the hormones themselves, estrogen and progesterone?
Well, estrogen has a complex role. Generally, it's considered neuroprotective, good for brain health. But significant fluctuations in its levels, those ups and downs, are directly linked in some studies to worsening OCD symptoms. It seems to be the instability, not just the absolute level, that can be problematic for some.
The instability, right. And progesterone.
Progesterone also plays a kind of dual role. It can have a calming influence on the brain, partly by boosting a neurotransmitter called GABA, which helps quiet things down. But here's the catch. A deficiency in progesterone, or maybe issues with how it's metabolized, can lead to increased anxiety and potentially worsen OCD symptoms. And critically, under chronic stress, your body can actually convert progesterone into cortisol, the primary stress hormone.
Oh, wow. So stress makes it worse in another way.
It can, yes. Yeah. This can lead to heightened stress responses and maybe impaired emotional processing. So these potentially protective hormonal mechanisms can actually become detrimental under certain conditions. It's a really delicate balance.
That raises an important question then. How do these hormone levels actually impact something as tangible as, say, brain activity related to OCD?
That's a great question. And that's where a specific neurobiological marker called error-related negativity, or ERN, comes in. You can think of ERN as your brain's immediate oops signal. It usually gets triggered when you make a mistake or detect an error.
Okay, like an internal alarm bell.
Sort of, yeah. In OCD, this signal can often be on overdrive, making you hyper-aware of potential errors. This can lead to things like excessive checking behaviors. What's truly fascinating is that research suggests levels of progesterone, particularly in that luteal phase, can directly influence how sensitive this oops signal gets. It seems to impact your response monitoring and sensitivity to errors.
So there's a direct measurable link.
It provides a potential specific measurable link between your hormonal state and the expression of particular OCD symptoms, like those checking behaviors. It's really groundbreaking work.
So what does this all mean for you, the listener. It sounds like the convergence of these hormonal fluctuations, the neurotransmitter dysregulation, the impact of chronic stress, maybe even sleep disturbances, it all creates this multi-layered vulnerability.
Exactly. It's not just one isolated factor. It's often a confluence of interconnected biological stressors. And these can form a kind of perfect storm during certain cycle phases, particularly that luteal or premenstrual period, leading to heightened OCD symptom severity for many women. And I think it is absolutely paramount to understand, to really internalize that this exacerbation is not a reflection of personal weakness. It's not emotional instability or some kind of psychological failing on your part.
That's so important to hear.
It really is. It's a direct consequence of complex, verifiable physiological and neurobiological processes happening within your body.
Wow.
And again, the recognition of conditions like PMDD in major medical classifications like the ICD-11 further validates that these cycle-driven mental health challenges are medically recognized and rooted in biology.
Okay, so moving beyond the purely biological for a moment, let's consider the broader systemic issues, because these can make this challenge even harder for women, right? The research you mentioned highlights a pretty significant disparity in funding for women's health research.
Yes, the numbers are quite stark. As of 2020, the statistic was that only about 10.8% of the National Institutes of Health's funding in the U.S. was allocated specifically to women's health research.
Only 10.8%. That seems alarmingly low.
It is, and that figure has real-world consequences. It contributes, many argue, to healthcare systems that sometimes fail women, or at least don't understand their unique physiological needs as well as they should.
How does that lack of funding play out?
Well, it leads to a broad misunderstanding sometimes of how diseases manifest and progress differently in women compared to men. There's often insufficient research into the efficacy and impact of pharmaceutical treatments specifically for female bodies. For example, dosages for literally thousands of drugs are still based primarily on studies done predominantly on male bodies or male cell lines.
Still? Wow.
Yes. And related research from 2020 found that women metabolize something like 86 different drugs more slowly than men. This leads to higher exposure and, consequently, significantly higher rates of adverse side effects in something like 96% of cases studied.
96%. That's staggering.
It really highlights the potential impact. And the broader impact isn't just personal health, it's economic too. Some analyses suggest that closing this women's health gap could boost the global economy by at least $1 trillion annually by 2040, and potentially prevent around 75 million years of life lost due to poor health or early death each year. That's like giving every woman an extra 7 healthy days a year.
The scale of that is huge.
The personal cost and the societal cost are immense.
So, for you, the listener, hearing all this, the cyclical intensification of symptoms, it can be profoundly distressing. People often describe it as an emotional and cognitive roller coaster, that double whammy we mentioned. The heightened intensity of intrusive thoughts, the spikes in anxiety, the increased urge to perform rituals during these vulnerable phases. They are legitimate. They are real. They can feel almost unbearable sometimes. And it's just crucial to validate these experiences, to reassure you that your struggles are shared by many and they are rooted in these biological mechanisms we're talking about, not solely in personality traits or, a lack of resilience.
Absolutely. And knowledge is most valuable when we understand it and can apply it. So the big question becomes, what can be done differently? How can we treat these symptoms, keeping this hormonal influence clearly in mind? Effective management of OCD symptoms, especially when they're influenced by your menstrual cycle, truly requires a multifaceted approach. It needs to be personalized and critically gender-informed.
Okay, so let's talk solutions. What about evidence-based psychotherapies? Where do we start there?
Well, cognitive behavioral therapy, or CBT, is generally considered the gold standard for OCD treatment overall. And a specialized subtype of CBT called exposure and response prevention, or ERP, is particularly powerful for OCD. ERP involves gradually exposing you to your triggers, the things that set off your obsessions, while preventing you from engaging in those compulsive responses, the rituals.
Right, breaking the cycle.
Exactly. But crucially, for those experiencing these cyclical symptom exacerbations tied to their hormones, ERP might need adaptation. It doesn't mean ERP doesn't work, but the application might need to be flexible. Well, it could mean potentially intensifying support during those vulnerable phases, like the luteal period. Maybe more frequent check-ins or adjusted session goals. It's about working with the cycle, not just ignoring it. Additionally, things like mindfulness and acceptance-based therapies can be highly beneficial too. They teach you skills to observe thoughts without judgment, without getting so pulled into them.
Okay, that makes sense. Adapting the therapy. What about pharmacological interventions? medications?
From a medication perspective, the selective serotonin reuptake inhibitors, or SSRIs, are very commonly prescribed. They're often first-line treatments for both OCD and PMDD. They work primarily by increasing levels of serotonin in the brain. And for PMDD specifically, the research shows SSRIs can be remarkably effective, sometimes even when taken only during the luteal phase, that premenstrual window.
Only during that phase, not continuously.
Yes, for some women with PMDD, luteal phase dosing works well, and often with a surprisingly fast onset of action. Sometimes improvement is seen within 48 hours, which is much faster than typically expected for depression or anxiety treatment.
Interesting. And beyond SSRIs, you mentioned hormone-informed care.
Right. This is really essential. It can involve monitoring your hormone levels to get a clearer picture of your individual patterns, and then exploring targeted hormonal treatments. Options might include certain types of hormonal birth control to help regulate fluctuations. Or, in more severe cases of premenstrual exacerbation of OCD, sometimes medications called GnRH agonists are considered, which temporarily suppress ovulation and the associated hormonal swings. Progesterone supplementation might also be explored for its potential calming effects via GABA. And research is ongoing into other potential hormonal interventions as well, like looking at growth hormone or pregnenolone.
It sounds like there are quite a few potential avenues there, needing careful consideration with a professional.
Definitely, it requires a knowledgeable clinician who understands these interactions.
And beyond the professional treatments, what about practical self-care strategies, things people can do themselves?
These can be truly transformative and empowering. One of the most important things, I think, is meticulous cycle tracking. By identifying specific patterns in your menstrual cycle and really correlating them with your OCD symptom intensity. Noticing when things tend to get harder, you can anticipate periods of increased vulnerability.
It's like having a roadmap.
Exactly. And this data is incredibly crucial. You can take it to your doctor, your therapist, and it helps inform those personalized treatment adjustments we talked about. It's a real game changer for many. Then there are stress management techniques. Things like meditation, deep breathing exercises, progressive muscle relaxation. These are highly beneficial for reducing general anxiety and maybe buffering some of that cortisol response. Prioritizing consistent sleep hygiene is also critical. We know lack of adequate rest can significantly exacerbate OCD symptoms for almost everyone. And don't underestimate nutrition. An anti-inflammatory diet might be helpful. Limiting caffeine and alcohol, especially during vulnerable phases. And some specific supplements like magnesium, calcium, and vitamin B6 have shown some promise, particularly for helping with PMDD symptoms that might co-occur with the OCD worsening.
Okay, lots of practical tools there.
Yes, and alongside those, it's vital to practice self-compassion and try to avoid maladaptive coping strategies. Remind yourself, and this is hard, I know, but remind yourself that your symptoms are often automatic responses rooted in biology and learned patterns. They're not choices or personal failings. Limiting reassurance seeking, gradually facing fears with support. These are empowering steps within therapy, like ERP. And finally, never underestimate the power of connection. Support groups, whether online or in person, can provide invaluable emotional support. They reduce feelings of isolation and offer a space to share practical coping strategies with others who truly get it.
That sense of community sounds so important.
It really is. And all this raises that important question again. How do you find this kind of personalized, gender-informed help? It's just crucial to seek professional care and really advocate for treatment plans that acknowledge the unique interplay of your OCD, your hormonal factors, and your individual life stage.
Okay, so if you're someone listening who feels maybe stuck, perhaps even after trying traditional therapy for years, you might be looking for a different approach. We came across one practice, Edward Jenny and Associates, who specifically state they aim to do therapy differently to help people who feel that way.
Yes, their core offering seems to center around what they call collaborative assessment. They describe it as an integrated, sophisticated way to assess your unique situation. The goal is to help you get to the root of issues faster, maybe gain insight into behavioral triggers, understand relationship challenges more fully, and ultimately gain deeper self-knowledge. Their tagline emphasizes being grounded in science, focused on healing.
And they do offer specialized OCD treatment, right? Alongside general psychotherapy and this collaborative assessment idea.
That's right. They mention offering OCD treatment specifically, and that psychotherapy and collaborative assessment can be done individually or potentially combined, depending on the person's needs.
What seems to make their approach different? based on what they say?
Well, they put a really strong emphasis on the relationship between you and your therapist, viewing it as the most important element for success, which aligns with a lot of therapy research, actually. They also talk about using assessments not just at the very beginning, but throughout the treatment process. The idea is to provide ongoing insight and maybe foster a sense of curiosity about yourself and your patterns. They also highlight leveraging the experience of their entire team, so bringing multiple perspectives to find the best treatment options for your specific situation. They talk about providing guidance and accountability, too.
So it's more than just one-on-one.
It sounds like it involves a team approach behind the scenes. They state their belief that therapy and assessment go hand in hand for the safest, fastest way to help you move forward. And they emphasize working with you, the client, as equals right from the start in that collaborative assessment process, discovering answers together.
That collaborative piece sounds key. And on a practical note, do they mention anything about insurance or access?
They do. They mention accepting traditional Medicare, which is important for some people. And they also partner with a service called Mentaya, which apparently helps clients save money on out-of-network insurance claims. So they seem to be considering the practical barriers to care, too.
Okay, good to know.
So just to kind of reiterate the main takeaway here, the evidence we have, the research, overwhelmingly demonstrates a significant and complex relationship between your menstrual cycles and the intensity of OCD symptoms for many women. This is a biological phenomenon, fundamentally. It's not a personal failing. And understanding it, really grasping it, is absolutely key to finding relief.
Absolutely. And if you're listening, please know you are not alone and your experience is valid. By recognizing these patterns in yourself, by actively seeking personalized care that considers your unique hormonal journey, and by cultivating self-compassion along the way, you can navigate these hormonal shifts and start to reclaim your life from the grip of OCD. You've got this.
And perhaps as you move forward, consider this. How might mapping your own unique cycle and symptom patterns, how could that not only empower you in your personal journey, but also how could sharing that lived experience, perhaps with researchers or clinicians, contribute to a broader understanding, an understanding that ultimately benefits all women seeking more effective, truly gender-informed mental health care in the future? Something to think about.